Greetings, RSNA 2020. My name is Eric England. I am the Radiology Residency Program Director at the University of Cincinnati. Today, we will be discussing Radiology Residency Program Management in the COVID era, strategy and reality. These are our goals and objectives. To discuss the challenges the COVID-19 pandemic placed on radiology residency programs and the need to adapt, propose solutions for residency programs to maintain the educational mission and resident well-being during the COVID-19 pandemic, and to examine how changes to the residency program during the COVID-19 pandemic could become permanent improvements to the residency learning environment. I have no disclosures. So what happened? This is a television monitor in our reading room where we frequently would throw up interesting cases. Early on, February 2019, during the pandemic, we would monitor when a new individual case was reported in the United States, and at the time, not really fully grasping the soon-to-be repercussions of a full-blown pandemic like we see in this map in September. The COVID-19 pandemic has drastically altered every aspect of our lives, in almost every way, and of course, radiology programs were significantly affected as well. Early on in the pandemic, nobody quite knew what was going on. This fear and uncertainty led to a significant amount of anxiety throughout the population. And I think this is well demonstrated by bare store shelves that we would see. I took this picture early on in the pandemic, first time I'd been to the grocery store, and was encountering bare shelves in almost every aisle. There were also headlines in the news, such as this one: "Do not call 911 just because you ran out of toilet paper." I don't think anyone could have predicted in 2019, a year ago, that these would be the headlines that we would be encountering in 2020. Despite this unknown, we must adapt. Our mission as educators to educate, teach, and inspire our residents really has not changed. Whereas before the pandemic, we get in small group discussions. On your left, you see one of our small group mentoring sessions going on. We must adapt and change how we teach and educate. And on your right, you can see one of our virtual meetups that we frequently have. So there's a variety of ways to adapt, and we'll talk about some of them. The unknown was a significant source of frustration among residents and really everyone. And one of the prime examples of this was with regards to the ABR. We really didn't know at the time when, how, if the core and certifying exam was going to take place. This led to a lot of anxiety among not only candidates who had fear that they wouldn't have time to adequately study and prepare for the exam, and questions on what if I'm pulled to serve on the front lines, but also among programs who were trying to figure out how to schedule residents, what rotations to schedule them on. And so this just led to a lot of fear and anxiety. The COVID-19 story is really a story of flexibility and adaptation. What did we do well? What did we learn? Where do we go from here? How can this experience enhance us as educators and learners? This image is an image of a fire lily. This species relies on fire to complete its life cycle. It actually senses when there is smoke and then knows when to bloom. And much like this fire lily rises from a forest fire, we must rise from this conflagration of a pandemic to really shine during this moment of uncertainty by adapting, collaborating, and forming new best practices in resident education. Early on, the ACGME came out with 3 different stages or categories that residency programs would find themselves in. Stage 1 would be business as usual, Stage 2 would be increased clinical demands, and Stage 3 would be the pandemic emergency status. And very quickly, we found ourselves in one of these 3 categories. So the earliest stage we might have found ourselves in was Stage 1, business as usual. During this stage, there were normal imaging volumes and procedures. The ACGME suspended all site visits, self-study, as well as the resident and fellow surveys. There was renewed emphasis on telemedicine, and this mainly affected other clinical specialties such as internal medicine and surgery. But the most important thing we needed to do in this stage was prepare. Prepare for the upcoming pandemic, prepare for the upcoming progression into stage 2 and 3. And in this stage really gave us the opportunity to do that. So what do we do to prepare in stage 1? Well, one of the most important things is preparing the IT infrastructure. We wanted to emphasize that residents who may be working off-site for a variety of reasons, either due to shift work or needing to quarantine, would still be able to participate in the learning and in clinical activities during the daytime. So this means making sure that residents had access to the electronic health records, access to our PACS, and were able to log in remotely to participate in some of these activities. We also wanted to expand our lecture topics, and of course the expansion of lecture topics would include topics on COVID-19, the imaging findings, and we definitely added these as our residents were on the front lines interpreting these cases. But also lecture topics on workplace safety, on PPE, knowing when and where to don certain types of PPE. This is very important to alleviate some resident anxiety, and so they know what our current best practices are for protecting themselves. But also expansion in leadership, adding some leadership topics as we go further down the stages. This is going to be extremely important for residents. And communication, really setting the seeds of a strong communication network between leadership, between program director, and between residents. And really kind of creating a reliable, consistent communication network, because a lot of changes are going to be coming down the pipeline as we progress through these stages, and they need to be communicated to everyone to prevent anxiety. So now we find ourselves in stage 2 with increased clinical demands. This is focused on clinical demands, hospitalizations from the COVID-19 pandemic. So really this is going to affect our clinical colleagues in medicine, critical care, surgery. But this is really going to increase their volume. But it affects radiology in a different way, because really we're going to be seeing a cancellation of elective procedures due to the COVID-19 pandemic. And elective procedures make up the bulk of a lot of what radiology sees. So the literature actually has that radiology volume during this time will actually, total volume will decrease about 50 to 70%. So we're actually going to be seeing a total of less work. During this time, fellows can actually function as attendings in their core specialty. And this is important as, some subspecialty sections may find themselves in certain situations where maybe certain faculty are quarantined, become sick, and can't practice in their core specialty. And fellows can then step up and actually help with the workload if necessary. This is also a great time to continue promoting social distance. It is imperative that we utilize social distancing to mitigate the spread of COVID-19 throughout the department. During this time, we can rearrange reading rooms, separate workstations, even put in plexiglass barriers. All these are great ideas just to decrease the chance of COVID-19 spreading throughout the department. So during this stage, we really had the flexibility to alter the resident work model. And this flexibility came from a decreased exam volume we just discussed. Thank goodness we addressed IT issues in stage 1, because a popular model that was adopted during this time was the shift work model. The shift work model functioned where we staffed fewer residents in the reading room. We had residents who were actually at home and would serve as backup in case one of the residents who were actually in the reading room became sick, ill, or were quarantined for other reasons. This was really great for our residents who were maybe in a vulnerable population or who had to deal with childcare issues. This was a frequent question and source of anxiety among some of our residents, in the fact that daycares were closing all over the country. They really didn't have anywhere to place their children. And adapting this model allowed us a lot of flexibility to have residents who had childcare issues able to stay at home and still participate in clinically. So this was extremely important. And have I mentioned communication? I mean, we're undergoing a lot of changes during this time, and constant daily communications through email or even through virtual meetings was essential to make sure everyone was on the same page as our work model shifted. So I'm at home now. What can I do? We really wanted our residents who are working at home to participate in activities that address the ACGME core competencies, and all these that we're describing do this. One of the first roles we had our at-home residents do was to assume the role of a reading room or call triage assistant. For those who don't know, reading room assistants can function in a variety of ways. At our institution, they help our on-call residents field phone calls, get in touch with physicians, get in touch with a technologist, and really help the on-call team be more efficient. Well, during this time, these reading room assistants were furloughed, so we didn't have those. And we were able to adapt and have our at-home residents participate in this role. So our at-home, we would forward our call number that usually goes to the on-call reading room to an off-site number where the resident was. And with residents having access to the electronic health records and PACS, they were able to really direct calls from referring physicians. They were able to protocol studies when they were on call. They were able to get in touch with physicians and relay urgent findings, and really serve as an efficient go-between that allowed our residents who were actually working on site to be much more efficient and really helped out in this role. And this helped them feel like part of the team. We also had residents who were protocoling patient studies while they were off-site. Usually during the daytime, each reading room will have residents protocol outpatient studies for the day or inpatient studies, but with residents at home with access to the PACS and electronic medical health record, these residents were able to perform these duties and go ahead and protocol studies, which allowed the on-site residents to focus on interpreting the exams. Now, we still wanted our at-home residents to participate in exam interpretation, and we were able to do this by having residents who were at home and still able to log into PACS draft studies on cross-sectional studies to our faculty members. Our faculty members would then look at it, and they would be on site on it and interpreting on a diagnostic monitor, and they were able to review these cases with our off-site residents, and so they would go over the study and findings either over phone or quite frequently over webcam. And this really helped our at-home residents feel like part of the team, and they were helping out while at the same time promoting learning. We had several of our residents participate in communicating with patient families, keeping them informed why their elective procedures were canceled, when we expected our elective procedures to revamp up, if there was issues where patients were really concerned about an urgent exam that may have been canceled, then we would work with their physician and try to get them in if necessary. This was really one-on-one communication from our residents to patient families, and patient families were extremely appreciative to have a physician call them and keep them up to date on what was going on in the department, especially when we started to bring patients back for elective procedures, to assure them that we were doing everything we can to provide a safe environment for them to return and get their imaging study. Now, don't forget, work hour requirements are in effect even if residents were working from home. This goes for all stages, but particularly this stage. So during this time, our education, or the way we educate residents, must adapt. And one way we did this was through virtual conferences. There are a variety of platforms available, including Microsoft Teams, WebEx, Zoom, GoToMeeting. All of these work great. We decided on one just so everyone would be on the same page and learning the same type of platform. And there was a learning curve to this. We found our faculty actually very quickly adopted this new format, and we were able to answer questions, but the participation and the desire to educate both from faculty and the desire to be taught from residents really helped make this a successful endeavor. We also had remote journal clubs. Some were the traditional model in which we selected topics or articles to have residents discuss during a virtual meeting. And then we also had more of a case-based model in which recent patient clinical presentations would be researched through journal articles and presented remotely as well. There were also a slew of online conferences provided by national societies, including the AUR, APDR, RSNA, just to name a few. And residents could view these many times at home or anytime they wanted. There was also a lot of online educational resources provided by individuals or organizations. There were several faculty members throughout the country who had YouTube channels in which they were giving their own lectures and sharing it amongst the entire country. And these were great. Several of them were very well, put together and very informative, and our residents loved them. There's also a goldmine of opportunities to access quality educational content on the web through social media, such as Twitter and Instagram. There were lots of great cases that were posted and topics discussed online. So a lot of great opportunities to continue to learn during this time. To create, innovate, and reimagine the educational experience. Virtual conferences are great, but it really makes engaging your audience more difficult, and it can be prone to distraction. So one of the ways we were able to reimagine resident education was through a virtual escape room. We would divide residents into small groups or teams and provide them with certain questions, cases, problems throughout the week, and these cases or problems would lead to clues. And if all the clues were found by the end of the week, you could solve the puzzle and we would declare one of the teams a winner. And this was really a great way to promote teamwork among residents in the department, because residents weren't seeing each other on a daily basis like they had been in the past. And this really allowed residents, even who were working off-site, to feel like they were part of the team and help out. We also utilized R1 pre-call simulation labs because we found some of our R1 residents, due to the shuffling of rotations, might be moved out of certain rotations that would prepare them for call. So for these residents, we created kind of virtual simulation labs in which they were able to adequately prepare. And we did the same type of situation for R3 oral board preparation type cases. We also created quite a robust amount of teaching files and case files, which would allow all our residents, even working from home, to participate and view interesting cases that were encountered throughout the day. So what about research? Well, there was a halt of all non-essential research involving study participants, and this was really for the safety of participants as well as the research personnel. But there were opportunities for virtual research, particularly for the residents. And these included EMR chart review, data gathering, data analysis, literature review, and manuscript writing. It was better now more than ever when residents had the time to participate to pursue some of these endeavors. So now we find ourselves in stage 3, which is the pandemic emergency status. This is really where the realities or challenges of redeployment take hold. One of these challenges was ensuring that residents met certain case log requirements. There was a lot of anxiety and fear among residents that they wouldn't be able to meet these requirements if they were redeployed for the floor. Fortunately, there was some flexibility. The main goal of the residency program is to ensure that each resident is competent to enter autonomous practice, and there was some flexibility with case log minimums. Of course, if residency programs weren't able to meet case log minimums in certain cases, then this needs to be addressed in the major changes and updates sections of the ADS. Particularly concerned, though, was nuclear medicine, breast, and IR. And for these, there was flexibility in allowing senior residents to interpret already finalized mammogram studies in a blinded fashion to meet these requirements and then have them reviewed with faculty. There was also the allowance for postgraduate documentation of I-131 administration, which was permitted, and ESIR residents were permitted to enter their independent IR residency even if they had met their log requirements. Now, in stage 3, there was a lot of redeployment. I'd like to read a short excerpt from a program director who was on the front line and reflecting on this experience. Despite extraordinary hard hits to the community in preparation to redeploy, the latter occurred in limited manner. Most on resident volunteer basis, but other residents faced mandatory redeployments with assurances of adequate PPE and training by clinical staff. Specific roles filled included redeployment to ventilated and non-ventilated COVID floors and true intern roles, as well as the central venous access teams. The toll was significant. Faculty development was needed as redeployment to COVID floors involved patient and family counseling, residents developed COVID symptomatology, the need for emotional support was extraordinary. This leads us into well-being, resident well-being in really all stages. How do we combat the uncertainty, stress, and anxiety during this COVID pandemic? The key is communication. For redeployed residents, not just communicating with the resident itself, but communicating with the programs in which they serve, keeping in contact with the residents to make sure that they are doing okay and they're having adequate supervision during their rotation and that their PPE requirements are being met. All these are extremely important for residents to know that you're continuing to look out for them. There's also illness, isolation, childcare concerns, loss of educational opportunities, and redeployment. Again, communication, flexibility, and trust in the program director is essential. Daily virtual huddles where residents can hear updates, pose questions, make suggestions, really empowers the trainees and gives them a sense of trust in their program director. Also, setting up one-on-one meetings and check-ins just to ensure that residents are doing okay is important. All faculty really should be hypervigilant to investigate suspicion of depression and stress that may develop in some residents. So during this time, we wanted to continue support resident well-being programs, and one of the ways we did this was through virtual workout challenges. Early on in the pandemic, when we were isolated from one another to a large extent, we challenged all the residents and included the faculty to engage in outdoor activity, post either a map of their run or activity on our chat, and we would donate money to a charity of their choice. This was really a fun activity that everyone got involved in. We also had happy hours and game nights that allowed a sense of camaraderie both among residents and faculty. The ACR did release Combating the COVID-19 Pandemic, a collection of well-being resources for radiologists, and these included a lot of self-care and fitness podcasts as well as webinars for residents to access. So where we are and where we are going. In the short term, I think we can expand the stages to include a stage 4 and stage 5 that are much more radiology specific. I'd also want to introduce the theory of punctated equilibrium and really how that parallels a lot of the changes in education that we're seeing. The theory of punctated equilibrium states that the evolutionary change is characterized by short periods of rapid evolution followed by longer periods of stasis in which no change occurs. So major events such as the advent of PACS or PowerPoint really change the ways we educate residents. And I believe this pandemic will also serve as a node for change in how we educate, similar to punctated equilibrium. We are on the precipice of major change in how we educate radiology residents. In stage 4, we'll see increased non-COVID clinical demands. Again, this is post-pandemic peak, radiology specific, and it's still important to maintain social distancing while we deal with increased number of patient encounters. There's an influx of new, previously delayed elective procedures. This is a table from a recent publication in Academic Radiology, which describes a responsible way to recover wisely and bring back this backlog of elective procedures. And this can be done by longer work hours, offsetting work shifts, as well as expanded responsibilities. But it's extremely important to, again, maintain social distancing while we bring all these backlog of procedures to get imaged. From an educational perspective, we're going to want to make sure senior radiology residents are meeting their ACGME requirements. First-year radiology residents are prepped and vetted for call, and for both of these, we may be rescheduling certain resident rotations, again, either to make sure the senior residents are on rotations to complete their requirements, and that first-year residents are rotating through specific call preparatory rotations, so they'll be prepared when they take on additional responsibilities in the next year. We also want to continue virtual learning as we had in prior stages. Regarding well-being considerations, there will be a significant increase in post-traumatic stress after dealing with the realities of redeployment and other stressors during the pandemic. It is important that access to mental health services are detailed to all residents and easily accessible. If residents had vacation requests that were deferred or limited, they should be given every opportunity to make those up. We also, again, want to ensure case volumes are met because this can be a significant source of stress. And again, communication continues to be paramount even in this post-pandemic stage. Now we're to stage 5, business as usual but redefined. Our radiology residency landscape will be forever altered, particularly for graduating residents who are really facing an uncertain job market. We should do our best to prepare these graduating residents for the unknown of the job market, and this can include expanding our curriculum to include content such as employment, contracts, negotiations, personal finance, to give them every opportunity to succeed in this new job market. As we discussed earlier, board certification was a significant unknown and cause of anxiety among residents, and this really led the ABR to change the board exams. All stakeholders were involved in this, and there was a commitment to virtual board exams from the American Board of Radiology. And these changes really lead to future opportunities for virtual examinations. Open dialogue between the ABR, PDs, and residents will remain essential in creating an enduring landscape of safe and effective examination, administration, and assessment. And this is really to be continued, but again, will involve all stakeholders in really creating a better test and exam for the future. I'd briefly also like to talk about the subject of medical student interest during this time. As we know from prior research, medical student interest is elastic and really directly correlates with the job market. Uncertain job market coupled with canceled or limited medical student rotations really could reduce the medical student interest in radiology. This is coupled with canceled medical student outreach programs, radiology fairs, and clinics in which we really showcase and highlight our specialty. Also, limited medical student research opportunities could lead just to overall diminished interest in our field. However, there is an opportunity to engage this generation of medical students who are digital natives and prefer immediate collaborative contact, and they are intimately involved in social media. We provide robust virtual experiences and, when allowed, welcome them back into the reading room with open arms. We can also use digital tools sharpened by our experience in this pandemic to expand the reach of radiology experiences to a larger virtual audience. In this next frontier, we must look to harness these new virtual learning tools in the post-pandemic learning environment. What will lectures look like in the future? Will we go back to the in-person didactic lectures? Will we continue with the virtual learning? Or will we adapt a hybrid model in which we can take the best of both worlds? We should further explore alternative side-by-side checkouts and really utilize these virtual checkouts. We'll also have more access to tumor boards and multidisciplinary conferences, which could expand resident involvement in these things. It's an interesting future, and I look forward to participating in it. Thank you. I hope everyone enjoyed this presentation, and I hope everyone enjoys
virtual RSNA 2020. Thank you.